Video of superficial parotidectomy. You will see the incision, the flap raising, the superior tunnel and the tragal pointer, the inferior tunnel and the digastric muscle, the nerve identification, branching, and the specimen. This is a video of superficial parotidectomy done on a patient with a lower pleomorphic adenoma of the parotid on the right side. That's the skin incision marking pre-auricular in the first anterior crease and extending downwards into the first transverse neck crease. The anterior limit of the incision is the anterior border of the swelling, and you also mark the angle of the mandible as a sulfus landmark. The skin incision is taken in the pre-auricular area. Reaching the subcutaneous plane and is extended posteriorly and inferiorly. We do not usually extend the incision posterior to the pinna to avoid a skin flap necrosis. In the neck crease, the platysma is then identified and cut, and you can also identify the great auricular nerve and the external jugular vein in most cases. A skin flap has to be raised. The preauricular area, it is in the suprasmas plane, that is usually a fat up, fat down plane. And in the neck, it is a subplatysmal flap. And the subplatysmal flap has to be connected to the suprasmas layer in the anterior face. If you continue meticulously in the subplatysmal plane, you may reach the subsmas plane, and then you have a higher chance of injuring the facial nerve branches, especially anteriorly. The flap is now completed, and it is kept retracted anteriorly with a stitch loosely tied. So in the lower flap part of the flap, you can see the platysma muscle, and in the upper part you can see the fat up and the fat down plane. Now the next step is to identify and preserve the posterior branch of the great auricular nerve, which supplies the lobule, and that is important especially in females who wear earrings. So we usually start from the lobule, dissect it, find the nerve where it enters, and dissect it downwards where it joins the main great auricular nerve. The anterior branch of the nerve may be sacrificed or may have to be sacrificed, but the posterior branch can be preserved. The nerve has to be carefully separated from its bed. A 360-degree release has to be done, means it has to be separated from the bed and kept aside posteriorly. So now you can see the nerve preserved along its whole length, and it is entering the lobule. So parotidectomy, the main step is to identify the facial nerve, and for that you have two landmarks. The first landmark is the tragal pointer, which is identified through the superior tunnel. The superior tunnel dissection begins in the pretragal area in the loose areolar vascular plane without breaching the perichondrium of the tragal cartilage. You can use monopolar in that plane, separating the fascia anteriorly with the traction. And make sure all the parotid tissue moves forward. And it is safe to use monopolar in this area of surgery. In the last part of, you can use a sharp periosteal elevator to identify the tragal pointer, which is a pointed part of the tragal cartilage, especially when the tragus is retracted. A wash is given for better visualization. And now you can clearly see the tragal pointer, and your facial nerve is about 1 to 1.5 centimeter antero inferior to this tragal pointer. And the next step is to do the inferior tunnel for the next landmark, that is the posterior belly of the digastric, for which you come down and the fascia over the anterior border of the sternocleidomastoid muscle has to be totally incised and pushed, separated forwards. The sternocleidomastoid muscle initially comes clear. So that's a sternocleidomastoid muscle. And then you do a gentle dissection to easily identify the posterior belly of the digastric. The nerve is usually anterior to the posterior belly of digastric in its superior aspect. So that is the posterior belly of digastric muscle. And then once that is identified, you can activate the nerve stimulator and test the nerve stimulator and see the muscle twitch, and that confirms your stimulator is working. And now you have two landmarks, and the intervening tissue between the first landmark, the tragal pointer, and the second landmark, the digastric muscle, has to be carefully dissected, and that is stimulator guided. You have to make multiple tunnels and take the tissue in between. It has to be tested with the nerve stimulator that there is no nerve fibers, and then burn it with the bipolar and has to be cut. Multiple such steps has to be done slowly, carefully, looking for the nerve in each step. And the layer of tissue is taken now. Tested with a nerve stimulator. And after confirming there is no twitch, you can bipolar it. And cut it. Yet another layer of tissue is being taken, tested, bipolar, and cutting. At this point, when you are nearing the nerve with the landmarks, you can do some nerve fishing with the nerve stimulator. By touching the tissue little deep, you may see the twitch and identify or get an idea or a clue where the nerve is, and accordingly you can do further dissection to identify the nerve. You have to be patient at this stage of the surgery, and then at a point you will get the stimulus and you will identify the facial nerve. The nerve is being located now. You may encounter a arterial spurter at this point, which has to be carefully caught and clipped. That part of this surgery is not seen here because that didn't happen in this case. So the facial nerve is now identified, and you are looking for the muscle twitch of the main trunk, the face, the lower and upper. And once you identify the nerve, the main trunk, the next step we say is the inferior kick. That is, you taking the tissue, staying on the nerve, the inferior parotid tissue below the nerve, staying on the nerve, directing your tonsillar artery forceps posterior laterally, and that gives a release of the tissue, and that will expose the main trunk further. If you're doing a superficial parotidectomy, meaning that you are removing all the superficial parotid tissue lateral to the facial nerve plane. Now, once you identify the main trunk, the next step is to identify the nerve bifurcation into the upper trunk and the lower trunk. Gentle dissection along the nerve will help you to find that. Further inferior parotid tissue is taken and bipolared. The nerve bifurcation is now identified. you can do individual testing of both the trunks to see the movement of the upper and lower part of the face. Here you can see the eyelids twitching. Now, after the identification of the division, if you're doing a superficial parotidectomy, both the trunks has to be dissected. Here the upper trunk is being dissected, staying on the nerve with the instrument, taking the tissue above it, bipolarating and cutting. This is a lower trunk dissection. You dissect along the nerve, keeping the nerve under the tip of the artery forceps, gently dissecting, pushing forwards and coming out, bipolaring the tissue with the instrument being held with an upward thrust so that it is away from the nerve which is lying below. And once the trunk is dissected, we will have to dissect the branches depending on the location of the tumor. So here the tumor is felt anteriorly, and keeping a cuff of tissue all around. The branches, individual branches are dissected till you fully separate the tumor off. There may be interconnecting branches which has to be carefully identified and dealt with. So you come around the tumor, preserving all the branches and separating the specimen off the bed with the nerve. The lower part of the dissection is being done now. The last part, the parotid tissue may reach the subcutaneous plane, and the specimen will be attached to the parotid duct, and that part you will have to dissect, maybe cross clamp, bipolar and cut, and the specimen has to be removed. That's the last cut, and the specimen may have the parotid tissue all around, or at some areas you may see the tumor little exposed. That is natural in a parotidectomy. And finally, hemostasis. The bed has to be irrigated well with saline. Valsalva maneuver has to be done to look for any significant venous ooze The main trunk in the end has to be stimulated to see the movement of the full face. That's a nerve preserved, and the facial nerve, main trunk, and the branching. That's the main trunk, the upper trunk, and the lower trunk. And finally, the closure. The facial layer may be approximated with the muscle first. A suction drain is usually placed, taking care it is not coming in direct contact with the facial nerve branches. Subcutaneous stitches first. The skin flap has to be approximated appropriately so that there is no misplacement of the pinna. Subcutaneous stitches first, and then subcuticular stitches to approximate the skin. Subcutaneous is usually done with vicryl, and subcuticular with absorbable sutures. I mean ethylone sutures. That is a closure in the end. Thank you. Subscribe to the YouTube channel for more videos.